Multiple sclerosis. So this is a 2094. This is a autoimmune disorder. So this is characterized by progressive demyelinating disease. There is demyelination of the myelin sheath. So these are the insulation, the covering of your nerves, okay, so of your nerves throughout your body. So this will cover all nerves. So from your brain to your spinal cord, which of course affects your muscles. So skeletal muscles are the mostly affected here. So this will be characterized by fatigue, pain, and muscle spasms, painful muscle spasms. Peak is between 20 and 50. So you still are within this age group. So you could develop MS. More women affected compared to men. So here's an illustration. This is what our nerves are supposed to look like. Intact myelin sheets. Now you have patches of demyelination. It's not that the nerve impulses are not transmitted. They are, but they are interrupted. They're not continuous. So therefore, can you smoothly perform a purposeful muscle contraction? No, you will have tremors and even pain, okay? Or there may be uncoordinated movements as a result because of these demyelination. Because it's autoimmune, we have no idea what's causing it. So we treat it as a autoimmune disorder, and this is not our first autoimmune disease. We've talked about arthritis, rheumatoid arthritis, lupus. So how is this treated? Autoimmune, immunomodulators, right? So immunosuppressants. And with everything else that have limited mobility, so what are the complications here? Okay, same thing as with spinal cord injuries. Plus, this one will have pain, of course. And because the patient is taking immunomodulators, so what's the complication? Okay, along with the complications of immobility, which include pressure ulcers, DVTs, although not as bad as spinal cord injuries, because these people can move, they just have decreased mobility. Okay. Plus, what will happen to you psychosocially also? You're between 20 and 50. Okay, so that's the number one impact for these patients. And you're female, right? So you could be a mom, you could be a head of family, and then you have the disease. Okay, plus you take the medications which cause you to be at risk for infections. So a lot of limitations. Yes.
I had a coworker, she ended up having surgery. Does it worsen? Like,
there are 4 types of MS. For our purpose, we will only discuss and test the most common type, which is the RMS, which is remitting, relapsing MS. Okay. Meaning this is chronic, so the patient will have periods of remission, but then they'll have exacerbations every now and then. They're not common. All MS is chronic. So we'll only do the first one, which is RRMS. So it's autoimmune. Not gonna test this part. So the patient's body develops antibodies against the myelin sheath, destroying them. So the only way to preserve the patient, what's left of the patient's nerves, is to suppress the immune system so they stop destroying the myelin sheaths. Manifestations again, besides pain, the patient will have the fatigue, the muscle pain, the muscle spasms. Here, fatigue, depression, weakness, numbness, discoordinate, lack of coordination, loss of balance, and I already mentioned pain. There'll be visual disturbances, double or blurred vision. Here, blurred or double vision. Some may have some blindness as well. So MS, depending on the severity of the symptoms, can be disabling. Okay? Some patients will become totally disabled. To prevent exacerbations or flare-ups, so they're told to avoid stressors, especially environmental stressors, which is easier said than done because stress is the stressor. Stress can come in any physical or mental or emotional sources, correct? It's very subjective. For pain, the patient is medicated with opioids because this is a neuropathic type of pain, from nerves. So patient will have may benefit from anticonvulsants, namely gabapentin. You know what gabapentin is? It's an anti-seizure.
Yeah.
You've seen it used in fibromyalgia as well. Yeah. Or in diabetic neuropathy, right? And antidepressants can be used. Typically, the tricyclic antidepressants are used. So here's the surgery that your friend may have undergone, but they're not really 100% effective. It helps some, but not every patient. How is your friend?
But she still has like periods of pain. So I guess it's still
Okay,
not-
yeah, so that's what I'm saying. No, it's not, yeah. Let's face it, there's no cure for MS. But if you're the one who has it, of course you'll try anything. So I guess your your friend tried surgery.
So much money to get this for?
Again, there's no cure. You can improve symptoms, but
Just like-
that's as far as it'll go. Menopausal age, older age patients will have osteoporosis. Plus, it doesn't help that they're on the immunosuppressants, so that will further contribute, especially steroids, and you know already about Cushing syndrome. So it affects the bone density as because these are long-term medications. Spasticity is what contributes to the pain, so the patient will will benefit from muscle relaxants. Baclofen is very effective in controlling the spastic pain. Bowel and bladder and sexual dysfunctions are common, again, between 20 and 50 years old. So sexually active patients, more women again than men. So this will contribute again to more depression. Okay, so you're supposed to be at the prime, yeah, it's your prime age, right? Between 20 and 40. 50. So with exacerbations, the patient would be placed on high-dose steroids during that period and then taper off as they go into remission. And again, the trigger is usually physical or emotional stress, which is quite common because it becomes a cycle. Because when you have this and then you have your relationships with your partners, for instance, can be frustrating, right? So you don't get, let's say, you're not intimate with a partner starts to screw around maybe, and then that contributes to depression. They get anxious, and then they get into another relapse or exacerbation, and then again the cycle goes on and on. So it's not easy. Management again is all supportive, as you can see. So we treat the symptoms, the pain. So there's pain management, muscle relaxants, antidepressants because of the depression effects. Rest, need plenty of rest, just like rheumatoid arthritis patients, and of course your prevention of infection due to the immunosuppressants they have to take daily. Again, no cure for MS. Purely symptomatic supportive management. I'm not testing table 64-2. I believe this is for doctors, right? Because this is about prescribing the what treatments to use. So we'll skip table 64-2. For the drugs, so this is the painful part. you need to know the nursing responsibilities, what to teach the patient, side effects, which includes precautions. Good thing is, are they any different from with we did from Guillain-Barré? So similar, right? So similar immunosuppressants, you know, they all cause what? Immunosuppression. For the injections, interferons beta 1 and beta B, and 1A and 1B, these are subcutaneous, so the patients will be giving them themselves, so they're taught how to self-administer. And these are the signs and side effects of interferons. So besides the bone marrow suppression, you also have increased liver toxicity, headache, depression. For skin necrosis, this is the injection site. Glatiramer is the most common, also subcutaneous injection. There is a oral form, which is fingolimod. So this is the most commonly used oral treatment. Yes. Yeah, rotate sites. So the most fatty part really should be the abdomen. So preferably the love handles. So those should be the best sites. The back of the arm, the problem with that is depends on the patient's body type. Yeah, I mean, some people don't have much fat on the arm. So, I mean, everybody has some love handle at some point, right? To a certain extent. Except maybe Miss Fabian. You have any? Anywhere? Yeah, I'll give it in your cheek. That's about, no, the cheek would be a bad idea. There's a lot of muscle here. As already mentioned, the patients with exacerbations or flare-ups will be placed on high-dose steroids. And we have metosantrone, which is IV infusion 4 times a year. Actually, on TV, I saw it the other day. Forgot the name. But it's twice a year now, infusions. So this one is still 4 times a year, but they're advertising something that's twice a year for MS. Twice a year infusions. That's not bad, right?
Pretty bad.
Yes.
For the lad.
All right, we already mentioned the symptomatic. Yes, that sounds right. Here are the symptomatic management. So for these tremors, because they have intention tremors. So when they move, that's when the tremors occur because of the, interrupted nerve impulse transmission. So they're given beta blockers for that, specifically propranolol. The other, propranolol is what they use for the tremors, the shaking. It's a beta blocker. So you'll see patients who are on psych meds who have tremors as a side effects of the psych drugs will be placed on propranolol. So typically antidepressants or people with OCD, because they're placed on the psych medications, they're typically placed on propranolol. There's no hypertension here. This is really for the tremors.
Yeah.
It's purely symptomatic treatment. They may be prescribed remember the ones you use for overactive bladder medications? But anyway, they're used to Yes, so those with bladder leaks, people like that. So they'll benefit
What's the name of the
from those
medication again?
medications.
Is it-
I'll tell you later. I can't. Starts with an
Yeah.
L.
Alphaleta, it's okay.
UTIs are also frequent with these patients. So anytime you have bowel incontinence, so they're at risk for UTIs. That's it for MS. Any questions? Okay, let's take a break.